Well, thanks to David Morrison for introducing today, and really thrilled to have the opportunity both to address you as a speaker today, but also to be part of this wonderful program. I think you'll agree it's a rich array of speakers and material that culminates at the end of the day in a hopefully lively and interactive roundtable session. So I hope that you can all stay until the end of the day. In terms of the structure of this, we will have 3 speakers, each of about 25 to 30 minutes each, with questions both after the individual speaker session and at the end before the first break and after the last break before lunch. During the lunch break, we hope to entice you into a tour of our institute here, of some of the laboratory space, and then the second session will start in the afternoon. First off, I'm going to be talking about an area, I think, which has become more familiar to most people, but it's still a bit foreign, and that's severe immunologically-mediated drug reactions, and how really there have been paradigm shifts over the last decade in terms of how we can actually approach patients, prevent severe morbidity and mortality in these patients, and what kind of roadmap this is actually forecast for the future. So in terms of my aims today, I'm going to talk a little bit about the background of this, success stories, examples, challenges, ongoing research, and then future directions. And I'm going to start with a case to really try and encapsulate what we might be dealing with here in the future, and in terms of prediction and prevention of these severe ADRs. So this was the case of a 35-year-old Indonesian woman who was HIV positive, a new immigrant, severely immunosuppressed, and she had a history of a reaction, past reaction to a sulfa antibiotic, and she was started on another drug to prevent a severe opportunistic infection, pneumocystis jirovecii, and 3 weeks later she develops symptoms of what would be defined as a drug hypersensitivity syndrome, and she stops dapsone. But then 3 months later, after she's already well, she is actually started on antiretroviral treatment with a combination that includes a non-nucleoside reverse transcriptase inhibitor, nevirapine, and 2 weeks into that HIV regimen, she develops again fever, rash, eosinophilia, and liver dysfunction, and she's diagnosed with nevirapine hypersensitivity. So the provoking question, I guess, to you all is, could this reaction have been prevented based on her immunogenetics, based on her HLA type, and that's her HLA type listed below there. And the actual answer in this case is yes, this actually could have been prevented. Not at the time she had this reaction, unfortunately, because these associations were not actually defined at that point. But since actually this patient developed this reaction, there was actually a paper that came out defining an association with HLA-B 1301, the dapsone hypersensitivity, as well as several different HLA alleles and nevirapine hypersensitivity syndrome. And since the last decade, there have been actually a large number of associations. This is actually an abbreviated list of HLA associations with severe, largely T-cell mediated drug reactions, and you can see these are heavily weighted towards class I HLA allelic associations with a few class II associations over here, and it really shows you that this list is continuing to grow and will continue to grow. But the question is, what does this mean for translation? What does it mean for the clinic? And what does it mean for immunopathogenetic insights into these various drug reactions? Another important point is that, as you know, HLA is not uniformly geographically distributed. In fact, the ethnicity, your own ethnicity, defines which HLA types and haplotypes you're likely to find in a specific region. And you can see from this review article that is outlining 2-digit HLA typing that there is actually significant differences in what's seen in the Western European world versus Southeast Asia, Africa, etc. And this is clearly relevant in terms of drug reactions, in terms of regional predisposition to drug reactions, for instance. In terms of actually a general landscape of defining adverse drug reactions, this has now changed over time, and I like to think of this, we used to think of this in terms of type A predictable and type B unpredictable, but clearly with type B reactions, we'd like to think these are becoming more predictable. And the pure T cell severe drug reactions that I'm largely going to be talking about do fall under the so-called type B off-target reactions, but these are now known to be primarily HLA associated, so they are not unpredictable anymore. So most severe T cell mediated drug reactions, and this list here is actually focusing on the cutaneous based ones, which I'm largely going to talk about. But now you can see that those with a check mark behind them, they are largely HLA restricted reactions weighted towards HLA Class I associations, as I'll describe to you. With Abacavir hypersensitivity being a bit of an outlier here in that it syndromically doesn't fit into any of the SCAR categories that you can see on the screen. So I'm going to go through a number of examples of different paradigms of drug reactions in the world of HLA and try and impart on you how things have changed over time, what are the challenges that lie ahead and what the future holds. So example one is actually a success story. It's an example of Abacavir hypersensitivity and the roadmap between the discovery of the association between HLA-B 5701 and Abacavir hypersensitivity. This is a particularly notable success story is because this hypersensitivity reaction was defined at least 4 years before the allelic association between B5701 and the syndrome, and there was already a stringent clinical management program in the post-marketing phase of this drug that was in place at the time that this discovery was actually fostered by 2 independent groups. And moving forward, basically, was actually the 6 years that followed this discovery was really the period of what we call T1 discovery to T4 through translation, which was a challenging period because there were a number of issues with this. There were apparently low sensitivity of the allele for non-white races because B5701 was underrepresented in non-white, non-European races, but this was really representative of false positive clinical diagnosis of the syndrome itself rather than lack of sensitivity of the allele. So through a number of studies and development of a specific immunophenotype in the form of patch testing, eventually there was widespread uptake into the clinic setting. And if you look at what was actually very important in the case of Abacavir, which will likely not be reproduced with any other drugs in the future, was actually having the appropriate combination of high-level clinical trials in addition to observational clinical experience to support the effectiveness. And in this particular case, you can see there was actually the PREDICT-1 study, which was the first randomized double-blinded controlled clinical trial to study head-to-head the genetic test versus the standard of care at the time, which was no screening, and clearly really imparted that by using patch testing to define true immunologically-mediated Abacavir hypersensitivity, you could see that the screened arm had absolutely no immunologically confirmed Abacavir hypersensitivity. Similarly, another study that was important was actually to look at the generalizability of HLA-B5701 across different populations, and the SHAPE study was really important in imparting the 100% negative predictive value of HLA-B5701 for non-white race. Also following this was actually a number of mechanistic studies that really gave the scientific basis for the mechanism of specificity of HLA-B5701 for Abacavir hypersensitivity. So what we already knew clinically with the 100% negative predictive value was nicely supported in a sort of bench to bedside and back again endeavor with 3 independent trials that were actually studies that were actually published actually within a month of each other, really to explain that Abacavir actually is able to alter the repertoire of self-peptides that are presented to T cells. And this was in fact paradigm shifting in terms of identifying a new mechanism for which drugs cause hypersensitivity reactions. And this was the altered peptide mechanism, of course. And this altered peptide repertoire model really was actually imparting what we already knew from the actual clinical and biological kinetics of the reaction, that drugs bind non-covalently with HLA, and they can occupy anchor sites within the antigen binding cleft, and this actually alters what the immune system sees itself into non-self and basically creates an immune response. It creates a form of altered T-cell immunity based on this alteration of immunological self by drugs. So this was a new paradigm that then became the standard to try and reproduce this with other drugs. And this was actually a beautiful example. Get this to here. A beautiful example of a combination of structural, biochemical, and functional approaches here that was able to solve the crystal structure of Abacavir and its relationship with B5701 and how it actually causes this reaction specifically at a biochemical and structural level. You can see the base of B5701 here, the beta-pleated sheets in purple here, Abacavir in orange, and the peptide in blue. And the peptide here in blue, really depicting the exact structural basis for Abacavir and its interaction with B5701. So another point that became very apparent in 2009, and Daly and her group in Liverpool defined a very strong association between the same HLA allele that's associated with Abacavir hypersensitivity, B5701, and another drug reaction, flucloxacillin, an antibiotic, and drug-induced liver disease. And this was actually really a really spectacular result here. But the actual translational implications of this discovery were to be quite different than that of 5701 and Abacavir as follows. So the issue with Abacavir was that the HLA-B 5701 allele is prevalent in European populations, about 5 to 10% carry this allele. And amazingly, the actual allele itself, not only did it have 100% negative predictive value in terms of no patients without 5701 develop Abacavir hypersensitivity, but about 55% of people that carry 5701 develop Abacavir hypersensitivity. And this has been different from any other drug reaction that we've defined on an HLA restricted basis today. Most of these drugs, as you can see, have lower positive predictive values. Therefore, the number needed to treat to prevent one case, unlike Abacavir, where this is about 13 to 30, would be over 200. And in the case of flucloxacillin, this is an extreme example where the disease prevalence of flucloxacillin-associated DILI is low. It's at 8.5 per 100,000, as you can see here. So even though this is a high prevalence allele in European populations, we would need to screen almost 14,000 cases to prevent one case of flucloxacillin DILI for a drug that's used commonly to treat a common bacterial infection. So this was going to be an example where this is a very strong association as defined by odds ratios, but it is not something that is going to actually make it into the clinical setting. Now, I'm just going to go on to talk about quite a different example now. And this is an example of a single drug with a single HLA association with a very severe clinical syndrome called toxic epidermal necrolysis here, where ethnicity does matter. So it's not only a specific HLA that's important, but it's actually within a specific population that this seems to be most found and relevant. So this is, of course, carbamazepine, HLA-B 1502, and Stevens-Johnson syndrome, toxic epidermal necrolysis. And similar to Abacavir, this is recognized early in the game to be a major cause of this severe disease, and a strong association in 2004 between HLA-B 1502 allele and carbamazepine SJS was reproduced. It was initially discovered by the Taiwanese group and then reproduced in many other Southeast Asian populations. In 2007, there was an FDA alert for the potential use of 1502 screening in Southeast Asian patients only, so this concept of selective race-based screening. And then actually in 2010, this became a funded test in Taiwan, and subsequent to that, there's been a dramatic reduction in carbamazepine-associated SJS-TN. So formally, this was actually the most common cause of SJS-TN in Taiwan, and since screening, it's now no longer the most common cause. As you can see, the rate has decreased dramatically, both from the introduction of 1502 screening and reduction of the off-label use of carbamazepine. And so now the greatest challenge in Taiwan is allopurinol, Stevens-Johnson syndrome, which has taken over as the most common cause of this dreadful disease. So relabeling of carbamazepine happened. Relabeling of carbamazepine happened, interestingly, even before relabeling of Abacavir happened. So in 2007, there was actually a label that selectively suggested screening in the United States, Canada, and of course in Taiwan. In addition, I've also imparted on you that 1502 is not a globally spread allele, so the hotspots for this are in Southeast Asia and India, and this is where the disease prevalence tends to be most notable, and so hence the selective screening, when we have the allele prevalence of 5 to 20% in these areas and less than 1% in these areas, you can see that the number needed to test to prevent one case in a predominantly European Caucasian population would swing in favor of potential non-cost effectiveness, but this has been a highly effective measure in these countries, or at least an efficacious measure, because actually one important point more recently that really highlights efficacy to effectiveness gaps, and this study was by Patrick Kwan and his group, who I think he's in Melbourne, but also has appointments in Hong Kong and does most of his studies through Hong Kong with carbamazepine in 1502. This study actually looked at the effect of the introduction of a screening policy on anti-epileptic drug use and its impact on subsequent severe skin reactions. And what they did in this study was they actually they looked at patients that were screened both following the implementation of this screening program, and they looked at the characteristics of what actually happened and basically how people acted on the advice of the whether the B1502 test was positive or the B1502 test was negative. So they compared the prescription data and the ADR data of anti-epileptic drugs pre and post screening policy and the adherence to the policy. And the results that they found were somewhat surprising. So they found basically, you can see quite dramatically that the actual, that the actual prevalence of carbamazepine SJS-TN fell off rather dramatically. But does anyone have a guess of why this happened? Why did it fall off dramatically? Did it fall off dramatically because B1502 positive patients were no longer getting carbamazepine? And just as a hint, look what's happened to phenytoin associated prescriptions. So basically what happened here, and I think this is again an awakening story, what happened here is that prescription of carbamazepine indeed declined in this population, but it declined not only in the B1502 positive population, but also in the B1502 negative population. And strikingly, what happened is B1502 negative individuals where carbamazepine could have been safely prescribed started to be prescribed phenytoin. And so the incidence of phenytoin SJS-TN actually increased significantly over this time period, such that the overall incidence of SJS-TN in Hong Kong did not change. And they also found that the adherence to screening abysmally was only less than 30%. So basically, this is, I think, basically a lesson in terms of, again, the efficacy to effectiveness gaps. We know with 1502 with a similarly negative predictive value to 5701 and Abacavir in Southeast Asian populations. If it's not prescribed, then patients don't get carbamazepine, largely don't get carbamazepine SJS-TN. But if we start prescribing another drug in those patients, even the negative patients, then you're going to start to see displacement of one onto the other. And so this is really, I think, a lesson that physicians in this study reacted to the new 1502 policy by not prescribing carbamazepine. So it's not that they used the results of the test, they simply, it was a marker not to use the drug at all. So I'm just going to close by talking about further examples that challenge traditional paradigms. And the paradigm that I'm really talking about here is that when we think about ADRs, type A versus type B, we've also always thought of type B reactions as being not particularly dose-related. And so a study was done by the Taiwanese group, again looking at phenytoin, the anticonvulsant drug I just talked about, and SJS-TN and another drug hypersensitivity syndrome called DRESS. And a GWAS was done on populations across Southeast Asia, but also Japan. And from what I've just told you, you would expect to see on this GWAS, you would expect to see a spike in chromosome 6 where the MHC is. But surprisingly, the spike here comes in chromosome 10. And does anyone know what's on chromosome 10 other than maybe Professor Martin that knows what's on chromosome 10 in terms of, we know there are MHC alleles, HLA alleles on chromosome 10. So what was actually this picking up in this population of phenytoin severe cutaneous drug reactions? Well, it was picking up actually a variant on CYP2C9. CYP2C9 is the actual cytochrome P450 enzyme that actually metabolizes phenytoin primarily, and the particular variant that seemed to be associated with these severe drug reactions was in fact the variant that's associated with decreased clearance of phenytoin. So that's CYP2C9*3. And it was significant across all populations of severe cutaneous reactions, sometimes called SCAR, that this seemed to be the most prevalent effect was actually the overrepresentation of this CYP2C9 variant in these populations when resequencing was done from the GWAS data. And so strikingly, this data set also showed, and this is in the supplemental data from this paper, that not only was this variant associated with the development of scars with phenytoin, but it seemed to be a concentration effect. So patients actually had higher total concentrations of phenytoin in diseased patients. So this actually shows right here the phenytoin concentrations in patients that have these various diseases, and you can see that they're actually higher overall in the patients that actually have the scars. And actually this is independent of CYP2C9*3. So although CYP2C9*3 was overrepresented, it appeared that other populations that also had higher exposure phenytoin also were at risk to get these severe diseases, suggesting that these are dose dependent. And the other paradigm shift here is that you would deduce from this that given that the parent drug accumulates in these types of patients, that it is a parent drug, not a reactive metabolite, that might be mediating this reaction. So that's the second paradigm shift. Allopurinol hypersensitivity, somewhat a similar story here. Allopurinol hypersensitivity syndromes, including DRESS and SJS, are associated with HLA-B 5801, another class I HLA allele, and this is actually being shown actually in very nicely in vitro studies that in fact the effect of the causative drug in this case is not the actual parent drug, but actual oxypurinol, and allopurinol is actually rapidly metabolized to oxypurinol, and oxypurinol tends to accumulate in patients with renal failure. And you can see here that again there was another study that was published that showed an association between oxypurinol levels and scars death, which again suggesting there's a concentration effect. And then the final example I'm going to show you is with again the HIV drug nevirapine, which is a cause of many different types of drug hypersensitivity syndromes, anywhere from the SJS-TN, the DRESS syndromes, as well as just rash and liver failure. And nevirapine is really highlighted by the fact that it has HLA promiscuity. So there are a number of different HLA alleles across different ethnicities that have been associated with these various nevirapine hypersensitivity syndromes. But it also appears, if we actually look at drug metabolism of nevirapine, and again, patients that actually tend to accumulate the parent drug that are, in this case, CYP2B6, B is in Bob, poor metabolizers, not D is in David, they tend to actually accumulate the drug, and they also seem to have a higher propensity to develop cutaneous reactions associated with nevirapine. And the other, I guess, interesting and I guess a bit of a paradigm shift that actually earmarks nevirapine from other drugs is that we've noticed that there appear to be strong HLA-B and C effects that appear consistent across ethnicity. You can see the different ethnicities represented there. But of interest with nevirapine, this effect appears to be largely driven by HLA-C alleles. So unlike the other drugs I've described and most of the new associations that have actually come into play over the last couple of years, it appears to be HLA-C alleles across ethnicity that appear to be driving much of the severe cutaneous reactions associated with nevirapine, with the additional finding that there may be a protective B allele effect as well, which actually negates the risk of that C allele. So existing models of drug hypersensitivity and HLA drug interactions have really honed in on the fact that we appear to be seeing a number of common alleles across syndromes, and those are listed there, and I'm sure we'll be seeing much more of this, certainly diversity in our drug hypersensitivity populations across all drugs and phenotypes. We see overrepresentation of these types of alleles. We also know that HLA is necessary but not sufficient for the development. So you've seen from the very low, less than 10% positive predictive values of HLA for the development of these diseases, that there are obviously other yet to be identified factors for many of these drugs. And so the mechanism of specificity of the interaction has actually been defined, but the other factors such as the tissue specificity, the short latency time for many of these drugs, so being T-cell mediated reactions, you expect them to be more delayed reactions, but some of them actually occur within 24 to 36 hours after first dosing. And these are not explained by traditional paradigms of T-cell immunology. So it leaves some unanswered questions. Just to present some data, this is from data that we've recently published on Abacavir hypersensitivity. And really, along those same lines, Abacavir really nicely illustrates those, that something different may be going on here. First of all, with Abacavir, we see the onset of first dosing, so in naive patients, to development of hypersensitivity within 5 days in a full quarter of patients, so it seems to be quick. We've also identified that there's Abacavir-specific CD8 cells from donors, basically, unexposed healthy blood donors, that these can be expanded both from sorted memory and naive CD8 T cells without the need for CD4 help. And there's also the observation that, I guess, extrapolating from these, the question is, could this be suggestive of a cross-reactive memory T-cell response, and where is this reaction coming from? Where is this cross-reactivity the source of it, and could it be actually a previously primed response to a chronic prevalent pathogen leading to this response, such as a heterologous immune response, as well described in the literature. So that just to take a step backward and think about this a bit, in terms of, I've talked a lot about genetics of HLA today, and we know that the real role of HLA is really to be able to recognize self, and that in T cells recognize HLA plus peptide, and in the context that there's a normal peptide in self-at HLA, we don't see any response. And if there's a foreign peptide, we see an immune response. So what could potentially go wrong in these cases if there's potential mistaken identity? So we can think of this as experiments of nature where there's well-defined autoimmune syndromes such as ankylosing spondylitis, rheumatoid arthritis, where we may see self-HLA plus an altered self-peptide. And we can also think of these as things we do to patients, such as experiments of man drug hypersensitivity where there's self-HLA plus altered self-peptide, as in the Abacavir example, or in terms of solid and organ transplantation where we actually have a foreign HLA plus any peptide. And in terms of the former with drug hypersensitivity, one hypothesis of what may be going on, and this will lead into Simon's talk that really hones more on this in terms of across all inflammatory and immunologically-mediated diseases, but it may be that the response that we're seeing quite distally to a drug is the result of a proximal response to a chronic prevalent virus such as a human herpes virus primary infection, which occurs to the large part in the first 10 years of our lives. And then at some later point, when the drug comes into the picture, we then see the presence of these, for instance, tissue resident. Many of these human herpes virus T cells, memory effector memory T cells, lie resident in tissues such as those for herpes simplex virus, the cause of common cold sores. They lie resident in human tissues. And then at some point in the future, when a patient is exposed to drug, the HV-specific memory T cells can cross-recognize endogenous peptide presented in the context of HLA plus the drug, and all of a sudden you get a bad reaction in the skin. So this is one potential model. The other point I'll just make before I close is that these new models that consider the role of cross-reactive memory T cell responses really, this could be a unifying hypothesis that really applies to any of the models of drug hypersensitivity that we currently think about. So in terms of actually the hapten, pro-hapten model, the pharmacological-interaction model, or the more recently defined altered peptide repertoire model. So just to conclude then, I've talked a lot about HLA drug interactions with the MHC, and again, just to re-emphasize to you that these appear to be necessary but not sufficient for the most delayed T-cell mediated drug reactions, and there's likely to be other factors that are actually driven and important here in terms of T-cell receptor clonotypes and that are indicative of previous, for instance, cross-reactive memory T-cell responses. The continuing definition of these types of associations, however, really open up things widely for future translation and mean that some severe drug reactions, such as, for instance, Abacavir HSR and carbamazepine SJS will be immunologically predictable and preventable, and we see this now as these have been now translated into the clinic in a widespread fashion. However, this doesn't mean that there aren't going to be translational hurdles, efficacy, safety, and efficacy effectiveness gaps, and I think the Hong Kong study of B1502 is a good example of that. But really the future promise and all the future promise and the translational frontier of the future is really going to be the ability to screen these risk compounds and inform drug development and design ahead of time in the preclinical phase. So with that, I'll just stop, and I'll thank all of the contributors to this work, and many of whom are in this room actually, and thank you very much. So I think maybe one or two questions, and then in the interest of time, I think we move on to your talks on it.
I guess I have a sense that you've identified individual examples where you have a dominant genetic determinant of a phenotype, adverse drug reaction. But what fraction of do you think you've explained by those, a single gene or dominant gene interaction models? I mean, when you, I suppose, as we go into an era where you can do whole genome sequencing, and you can identify rare as well as common variants, and presumably where you start to be able to look at interactions between loci as well as single genetic models. I'm just wondering what fraction you could anticipate explaining over the next 5 to 10 minutes.
Yeah, and I think, I think based on the model that I showed at the end, basically much of that is going to be outside of the capability of sequencing in terms of being able to pick up the exact immunopathogenic basis of the gap between HLA, for instance, or a risk allele and the actual phenotype itself. And the actual reason for that is probably it's due to some external factor that happens, such as a response or an early response to a virus or a pathogen or something else that comes into play. And so I think what this is really honed in on, and there's been a few GWAS studies and the interactions have been looked at, and we've certainly done this with Abacavir, and it's still evolving with Abacavir, that there does not seem to be explainable largely. It seems to be largely explainable outside of any haplotypic, haplospecific markers or any other gene sequencing that can be readily identified by those methods. And I think that's also in support of having an alternative model, such as there's an acquired factor. So where it starts to get really interesting is when you start, and there aren't many examples of this, but there are clear examples of family members that carry the same allele and do both get a drug hypersensitivity reaction. And there's a handful of examples, but there's also examples of family members that carry the same HLA allele and they do not. One of them tolerates the drug and one of them actually gets a reaction. And I think this is also in support of the fact that there's some early immunodominant response that's occurring to some prevalent pathogen to actually drive this forward, rather than something that's actually in the genome that would be more predictable over time. So there's just a question.
No, that's okay.